So you have a 28-year-old young lady who immigrated from Thailand 5 years back. She's having progressive back pain and lack of appetite and difficulty ambulating. She's not formally diagnosed with Marfan syndrome, but she's kind of lanky and pretty thin. And have some diffuse weakness and hyperreflexia. So here's her x-ray. And this is actually a case that Lionel and I did together. So can you describe the x-ray for us?
Positive sagittal imbalance. I'd have to look at the actual pelvic parameters there, but looks like there's some pelvic retroversion going on as compensatory measure. So I think next I would get an MRI to work up her hyperreflexia, given that some concern for myelopathy. If she's hyperreflexic in the uppers, might localize to cervical spine, but I'll get a total spine MRI and CT scan total spine as well.
Okay, good. And we have all those, and that's coming up. Can you tell us a little bit more about the coronal alignment? Which type of the coronal malalignment is this?
Well, I think I would typically draw a plumb line from C7 and then measure it a perpendicular from the central sacral vertical line to determine the amount of coronal imbalance. But in terms of the classification, I wouldn't be able to tell you.
Okay, so it's a type B curve because it's shifted to the sort of the concavity of the curvature. So if you correct the major curve, the spine shifts back. But type C, where when you correct the curve, it'll shift to the convex even more. So that's always something to take into consideration. I don't know if the Cobb angle projects well, but coronally it's about 150 degrees, and sagittally in the TL junction it's about 140 degrees. So here's her clinical picture. You can see that her sort of abdomen is sort of very shortened, and she has pretty poor appetite and have early satiety. And
Lee, would you go back to that standing film? I just want to. I think you're right about this being bowel B and an OB2. The point being that in the coronal plane, that translation of the trunk opposite the convexity of the thoracolumbar curve, to some extent, that's a bit of an advantage. When you got the ipsilateral convexity and translation, that makes it more difficult. The other subtlety here that I think is important to see is the shoulders. So it's a little bit easier if that left shoulder were elevated, because that would truly be, hey, I can do an angular correction across my convexity, level the shoulders, and bring the trunk back. But the fact that the shoulders are level here is really an important consideration, because an angular correction is going to suddenly bring that left shoulder down, right? So the typical bow B or the typical OB2, the shoulders being up works to your advantage. But here, you really need to horizontally translate the trunk. It can't be done with an angular technique. And I think that's a really important subtlety to recognize in these coronal shifts, is that this is going to require translation, and the only way to translate the spine is to be with a VCR. To use angular techniques is just going to exacerbate that shoulder asymmetry, and it's the subtlety, I think, that's really worth pointing out in this x-ray. It's a great example.
Yeah, no, thank you for pointing that out. That's a great point, actually. So, Tim, you asked for CT. What do you see here? This is axial CT across the TL junction. So the arrows are basically pointing at the concavity, and you can see the pedicles are pretty thin, right? And then because of the coronal deformity, in certain sections, it's you get a coronal view there. So here's the MRI. Can you comment on the position of the cord?
Looks like it's positioned off to the left, fairly capacious central canal there.
Okay. Does that worry you during surgery? What consideration do you sort of
With the small pedicle and the cord adjacent to the pedicle at the levels that need to be cannulated, medial violation could cause cord injury.
Right, exactly. And sometimes, as you do during the operation, the cord can actually sort of shift and compress against the pedicle, and you may have to do a pediculectomy if there's a sort of cord signal change. But certainly, I think several speakers have mentioned this. Having a 3D model made to understand the complex structure is very helpful because, on the 3D CT or MRI, the cuts are never perfect because of the significant deformity present. And I find having the 3D model made really helps you to understand the deformity. And in this case, you can't see here, but on the CT and the 3D model, the patient's basically fused across the kyphus from, I think, a T12 to L3. So what do you want, what are some of the considerations? What's your treatment plan?
So the considerations are the need for, like Dr. Berman mentioned, translational correction, as well as restoration of sagittal alignment. So 3-column osteotomy would be necessary, like VCR, and then,
Sure. Where are you going to plan your VCR? I know it's hard to see, but from studying the model, the apex is L1. Basically.
I think I would typically put it at the apex of the deformity.
Okay. And in terms of instrumentation, do you want, tell me about the OR setup. What equipment do you want to have?
So it'd be Allen frame, chest, hip, and thigh pads, C-arm, O-arm, with stealth or brain lab navigation. And then definitely need temporary rods for during the osteotomies, neuromonitoring, potentially ultrasound if we need to do decompression and take a look at the position of the cord.
Okay, great. All right, and the levels of instrumentation and
so I think cephalad, I would take it to the stable and neutral vertebra. I'd have to count, but I would think it'd be mid to upper thoracic, and then take it down to the pelvis.
Okay. All right, so yeah, you said about the navigation, and that's exactly what we did. I think freehand is okay. I mean, like Larry does these cases freehand, just look at the spine and put it in. But I think with navigation, you just have, this part becomes less stressful. It's still very stressful, but much less stressful. And for some of the, very type C, type D pedicles on the concavity, you can really, actually be safe, just do a perpendicular screw, right? Not even trying to go through the pedicle. That way, the cord is completely safe. And so here's just basically some intraoperative pictures showing the pedicle, CT showing the pedicle screw placement, and some of them are perpendicular on purpose. And I think, because of the severe rotation of the spine, the navigation is super helpful. So in terms of correction, you've placed your screws and you've done your L1 VCR. What are some of the considerations to sort of get the spine corrected? Now you've decompressed the apex, you've loosened up the spine. Can you tell us some ideas? These pedicles are very small. How would you, what steps you can take to minimize screw pull out and get the correction you want?
Well, I try to avoid stress on any single screw at any one time. if the bone quality is poor on pre-op imaging, potentially cement augmentation of screws, but I think potentially trying correction by like reducing the polyaxial nature of the screw head, either putting in monoaxial screws or locking the poly screws into a mono configuration, and then putting a rod down across maybe 4 to 6 screws at any one time, and then performing the reduction maneuver.
Yeah, no, that's basically what we did. So you're saying construct to construct maneuver, right? So you can see we have 3 rods here. The cranial screws is connected to 1 rod, and then the caudal screws are connected to 1 rod, and then a 3rd rod sort of expand across, and then you can compress each region so that the force is not distributed into any single screw. That way you get a very forceful reduction. So again, compress on the convexity and distract on the concavity with the same idea. We got just less than 100 degrees of correction, but still with some residual curvature given the rigidity of the deformity. But you can see there's a significant increase in the abdomen height. So she actually gained about 2 inches or so. And this is the before and after with the rib hump improvement. And not perfect coronal alignment, but it's improved compared to before. And sagittally, again, also just got about 100 degrees correction, not perfect. Is there a clinical picture here? And fortunately, we didn't have any neural monitoring changes, and she's actually improved. She still kind of leans to that side a little bit, but walking much better. She's about 2 years out now, so good job. All right, you want to do one more? Or any? Yeah. Do you have a case? Yeah. Yeah.
All right, so we'll go from sort of chronic deformity to what I think is probably a little bit easier, acute deformity or trauma. So I have a case just regarding like lumbopelvic fixation. It's sort of at the lumbosacral junction, sort of at the, it's at the ends of what, the orthopelvic trauma surgeons treat and what the spine surgeons treat. And so we have a couple different ways to address these injuries. The mainstay are really, so what I wanted to get at is just like when we choose iliosacral fixation and what what patients can benefit from lumbopelvic fixation. I think we probably underutilize this. We have a couple cases here. So this is the first case. So a 43-year-old homeless man was on top of a 40-foot building. Police tried to de-escalate and he ended up jumping. And so he came in with he's hemodynamically unstable, but neurovascularly intact. So maybe Rafid, take you a little bit back to your ortho trauma days, so more than a year ago. What sort of stands out with these pelvic films here?
Positive Throckmorton sign first. No, but I mean, this is a very unstable pelvic injury. There's depends on the mechanism, and it looks vertical shear to me on at least the left side, and the right SI joint. I'm looking at the left picture on the screen. The left SI joint is open as well.
Yep.
So bilateral pelvic ring injury.
Yep. So we won't belabor like the acute points, but that's exactly what I see. So you have the hemipelvis, a vertical pattern. It's externally rotated. It's flexed up. And so initially the patient went to IR for embolization, got stabilized. He was stable enough for a pelvic X-fix that buys you a couple days. And this is sort of the post-op CT with him a little closer. And so does this give you any additional information? Or?
Yeah, so we see, again, the open SI joint on the right. And then on the left side, there's a sacral fracture that looks to be going through the foramen and even medial to the foramen. So, that's the highest rate of neurologic injury. You want to do a good neurologic exam.
Yep.
60% rate of injury with those types of fractures. The pubic symphysis is not quite reduced, but much better than, much better in the X-fix.
Yeah, exactly. And so from the pelvic ring standpoint, the majority of treatment is iliosacral screws. So how well do you think iliosacral screws with like the sacral comminution there are going to be able to really hold that left hemipelvis?
No, not well at all.
Yeah. Because the sacrum, there's only, the ala are notoriously like it's poor bone, and we don't know much about him as a host.
Yeah.
So the pelvic trauma surgeons are going to, stabilize the front of the ring, but they're going to want supplemental fixation at least in the back. Okay.
There might be a big enough piece to put a transsacral screw across both.
Yeah.
But
Yeah, and so that would rely on getting it reduced. And this guy, it took maybe 6 or 7 days to get him to the OR where he was stable enough for an open procedure. And then really pulling down that pelvis really becomes hard, And so this is where, like, as spine surgeons, we have, we can leverage our, our understanding and actually use the lumbar spine to help bring that hemipelvis down. So, in conjunction with the traumatologist, the plan was for an anterior ring ORIF PERC SI screw on the right side to close down that joint, and then an open posterior sacral fixation. So the pelvic surgeon, fix the front. The front is usually left somewhat flexible so that the back, if the back is not reduced, you can still mobilize it and percutaneously close down the SI joint there. And then sort of flip the patient, open the back, so this is this patient's sort of image in terms of the soft tissue. Your thoughts on how that muscle looks and
that's the
posterior, it's a left paramedian sort of approach.
Yeah, a lot of hemorrhage and almost the Morel Lavallée lesion.
Yeah, exactly. So, and this is what historically gave open lumbopelvic fixation techniques, a higher complication rate with over 50% reoperation for either infection or persistent CSF leaks and this sort of thing. So despite all the traction, the pelvis is still 2 centimeters approximately migrated. So any thoughts as to anything else we could do to sort of pull that down? Or
the pelvis is migrate which direction?
Proximally, and there's diastasis posteriorly. So.
There's various reduction tools for this. There's a large C-clamp that you can use in these situations.
Yeah. Historically, the C-clamp would be used to pull it, but most hospitals, you can't find it now. It's somewhere in central supply. So what we started doing is, putting a cannulated 4-5 screw into L5, and then another one into the ilium, and using one of our other clamps. But before we get to that, so you have to instrument the ilium. So like, how do people instrument the ilium? Are people freehanding or navigating or using some sort of imaging on fluoroscopy?
Yeah, I think, my experience in fellowship, various techniques. If you're putting iliac bolts, that can be reliably placed freehand just with a gear shift. If you're putting S2AI screws, I think you need image guidance.
Yeah, and if you're freehanding it, what's sort of quickly, like how are you doing that?
For the iliac bolts, you expose the ilium, you can decorticate the iliac crest, your choice. I like to use the osteotome and make a little rectangular corridor, and there's usually room for 2 iliac bolts. You angle about 40 degrees, and it's pretty reliable.
Yeah, and I think in the intact pelvis that works well. But if you have some internal external rotation in descending a trauma, that's a little less reliable. I think navigation is a good tool, but the downside in trauma is sometimes the pieces are it's where you're going to put your fiduciary. So if you're going to cannulate the ilium, you would probably put it in that ilium too, the same one. But it may not give you as much reliable if you're trying to instrument the contralateral side and that sort of thing once you start reducing the fracture. So in trauma, my go-to technique is just to use fluoroscopy, and I just simply think of, every column, the pelvis, it's a funny shaped bone. There are many osseous corridors. They're like huge pedicles. And the way that we define pedicles in space, like in terms of when we're instrumenting them, is a start point, a medial lateral trajectory, and a cranial caudal trajectory. The red box is where we're putting these iliac bolts. And a lot of times we will rely on the teardrop. The issue with the teardrop, I think the teardrop's great at identifying your start point, but then when you're putting the instruments in, it's in the way of where your hand is. And then again, if we go back to the idea of it being a cylinder of bone, we could define the cylinder by an en-face view, which is what our teardrop is. But if we take two other orthogonal views that are reproducible, then we can find views that can help us guide our cranial caudal angulation and our medial lateral angulation. And these other two views, we'll sort of go through these quickly. These are the same views that we use to put on an anterior pelvic X-fix. So these are sort of widely used. So the first is this, the obturator inlet. And I have a better view. So this is sort of the way how we're looking down on the pelvis there. And this guides our medial lateral trajectory. I had another slide here. So yeah, so this is the one view that guides our medial lateral trajectory. That's the SI joint there, the ilium, the inner cortex, the hip. And if you're doing an S2AI, you're starting just medial to the SI joint. And then if you're starting using your standard PSIS, that's where your start point would be. And that's really your safe zone. Those are your sort of, and then the other view is just our iliac oblique, where we're just looking at the iliac wing, where you can see the notch and the AIIS, and you're just aiming down the AIIS, because that's where our teardrop is housed. And so then this becomes sort of where we want those screws. And then you could use these to redirect, to direct screws around other existing hardware, SI screws and that sort of thing. So going back to the case, this is sort of the clamp. This is not where we're going to put these screws, but this is the young Bluth clamp, which we use frequently in pelvic surgery, where you just put two screws in the two fragments and you can hook onto them and rotate them. So that's what we did here. So you have the screw here in L5, and this is the iliac cannulated screw. And then here you can see that the pelvis is still elevated compared to the L5S1 disc. And then if you use this then to distract, to push the ilium down, you can bring it, you can see that ilium sort of coming down. And now there's diastasis, and then you could just then simply just clamp across or rotate the young Bluth to get that reduced. And so here we clamped it. And then once we clamped, you have your pelvic colleagues put in an iliosacral screw if there's a corridor, and then everything can come out. And you replace everything with, your hardware. And so this is sort of like the iliac screw, like based, with fluoro, you see the entire corridor. And so you could get, like up to 120 screw, which we want in these trauma patients, so that, and then the cannulated screw you use breaks off when you try to take it out, because you could see the amount of bend, the amount of force that was on that screw, which is okay. We leave hardware in pelvises all the time, so. Yep. So I don't know in terms of timing. Okay, we'll do a quick one. So that was like an open displaced sort of fracture. We'll skip through this one. Let's get through this one. Actually, let me go back. So in sort of looking through these injuries, there's a huge spectrum of injuries. And these are really the questions that help guide, me to think about, PERC pelvis fixation versus like, what are we doing? So if there's neurologic symptoms, you're decompressing. If the fracture is non-displaced, you don't really have to do a reduction, or you can try PERC. And then you need to ask yourself, do you need to fuse the lumbosacral junction or not? We only do that if there's like a displaced facet fracture. And then how we're going to instrument. So we could do these instrumentation percutaneous. So we'll skip to what we're seeing more and more, these sort of fragility fractures. So this is a patient, with an ankylosed spine who came in with persistent pain and functionally limiting pain. So he has a fused segment that's autofused above, and this U-type sacral fracture, and he can't get out of bed despite like a trial of PT. He has reasonable corridors. If he wasn't ankylosed from the pelvis side, we probably would just treat this with iliosacral fractures. But what we know sort of from our spine side is these fractures below a long fused segment typically require something a little bit more robust. And so if we go to our questions, he doesn't need a decompression. The fracture's already reduced. We don't need a fuse any, the junction, it's already auto-fused. And so we could potentially instrument this just percutaneously. And typically the lumbopelvic excision, I'll go only up to L5, but because he's already autofused, I just took it up another level. And you could do these through pretty small incisions, you know. So for the L5, you have the two for the towers for L5, and then the single midline incision where you can put both iliac bolts in, because those are going from medial out lateral. And you just make separate fascial incisions, and that's sort of how the instrumentation looks. So, and then they're able to have them ambulate. So.